In this video lecture, we will be covering chapters 13 and 14. So chapter 13, it's about altered hormonal metabolic regulation. So our hormones in the endocrine system, they have several features that are common to all hormones. And in the case of control, the hormone synthesis is controlled and they're released as well by several tissues and organs that are located within the hypothalamic-pituitary axis in the brain, and then this is an important control center for many hormones. Now, hormones adjust in their amount based on negative and positive feedback loops. So while negative feedback loops tend to decrease the production of hormone, positive feedback loops will increase the production of hormones. Now, many of the hormones that we have in the endocrine system, they exhibit a predictable pattern of expression. For instance, the hormones of the female reproductive system during reproductive age, estrogens and progesterone, they follow a pattern, cyclic pattern during the month. And then the hormones, they have to bind in order to exert their effect. They have to bind to receptors. And these receptors are specific for a specific type of hormone. For instance, receptors for thyroid hormones will not respond to estrogens or other hormones. And we have receptors within the plasma membrane of cells or within the nucleus. Now, the hormones have an action, and the primary actions of the hormones is to increase the activity of the cells or the tissue by increasing transcription, or make the cells within a specific tissue to produce a hormone that is going to act over a distant tissue. So this is the diagram that shows you the hypothalamic-pituitary axis, and within the hypothalamus we have many releasing hormones secreted that are named with the ending H or RH, and these are thyrotropin releasing hormone or TRH, corticotropin releasing hormone or CRH, gonadotropin releasing hormone GnRH, and growth hormone releasing hormone or GHRH. All of these, they will go into the pituitary gland, the anterior pituitary gland, using this hypophyseal portal system that we have. So these are capillaries that brings the hormones that are produced by the hypothalamus, and they travel through these capillaries, reaches the anterior pituitary gland, and the anterior pituitary glands, they start secreting the different hormones that are produced within the anterior pituitary gland. So in the case of thyrotropin releasing hormone, it stimulates for the production of a hormone that we call TSH, or thyroid stimulating hormone. This TSH is going to go into the bloodstream, is going to reach the blood vessels in the neck that provides blood supply to the thyroid gland, and then the thyroid gland is going to produce thyroid hormones like T3 or triiodothyronine, and then T4 or tetraiodothyroxine. In the case of CRH or corticotropin releasing hormone, it's going to stimulate the production of ACTH in the pituitary gland, or adrenocorticotropin hormone. This ACTH is going to go and bind to receptors within the adrenal cortex So your adrenal gland can start producing different hormones like cortisol, glucocorticoids, and other ones. Now, for GnRH, gonadotrophin-releasing hormones, these will stimulate the production of FSH and LH, and FSH is going to stimulate the formation of follicles within the ovaries and is going to start promoting the formation of uh, also in the males the production of testosterone, and together with LH is going to also increase the production of sperm cells. Now in the case of LH in the females, it's going to stimulate the ovulation of the egg cells by the ovaries. For growth hormone releasing hormone, or GHRH, is going to just stimulate directly the anterior pituitary gland to secrete growth hormone, which is going to stimulate the growth of soft tissue and bones. Now the posterior pituitary gland is not producing any hormones. It just stores the hormones that are actually produced by the hypothalamus. Examples of these hormones that are produced by the hypothalamus are oxytocin and ADH, or antidiuretic hormone. So again, ADH and oxytocin are produced by the hypothalamus, but they are stored within the posterior pituitary gland or neurohypophysis. And then when oxytocin is released, it's going to stimulate the contraction of the muscle cells, smooth muscle cells in the uterus during labor. And in the case of the lactating woman, she is going to have contraction of the myoepithelial cells in the mammary gland so that it can have ejection of milk, the mammary gland. In the case of the males, oxytocin, it produces contraction of glands within the reproductive tract, and also helps in the ejaculation process. Now for ADH, it's also known as vasopressin. It's going to increase the absorption of sodium and reabsorption of water by the kidneys. So in this diagram that you can see here, you have a feedback mechanism, which is the negative feedback. And within the negative feedback, in this case, you have several factors like cold temperature, stress, and TH levels that are going to stimulate the production by the hypothalamus of TRH, or thyrotropin releasing hormone. And then when the hypothalamus produces this TRH, the pituitary gland is going to produce TSH, and then this TSH will travel along these blood vessels. It will reach the thyroid gland, and then the thyroid gland is going to produce T3 and T4. And once you have enough T3 and T4, you will send a feedback mechanism into both the pituitary gland and into the hypothalamus, so you decrease the production of TRH and TSH. At some point, T3 and T4, I didn't mention it before, they increase the metabolism of our cells. So thyroid hormones controls metabolism. Positive feedback. It happens less time than the negative feedback, and is when you have high levels of hormone but you need more. In the case of oxytocin, this hormone works with positive feedback loop. So as I said before, this hormone is necessary for the contraction of the uterus during labor. So when the heads of the baby it is pushing against the cervix during labor, that is going to stretch the muscles of the cervix. And then the cervix, through this connection of the nerve cells, is going to send a signal to the spinal cord, and then that signal goes into the brain. And then within the brain, you will start stimulating the production of oxytocin, and that is going to be released into the bloodstream. It's going to reach the uterus, and the contractility of the uterus is going to increase, and then you will have more force of contraction so that the baby can born. Okay, so we have different ways in which the cells communicate, like the paracrine way, in which hormones are produced in the vicinity of certain cells, and these cells, neighboring cells, will receive these hormones, and then they will start changing their behavior. Autocrine is when some hormones act on the same cells that are produced. Endocrine is when the hormones are released into the bloodstream, and then they act over a distant uh, organ or tissue, and then you have the effect. Synaptic pathway and neuroendocrine pathways are similar, in which you have axons sending signals into target cells directly. And in this case, the action will be most immediate than with the endocrine pathway. Okay, so for the stress response, so cell-to-cell communication is always needed for having a stress response. And stress is defined as the body reaction to harmful forces or stressors that are capable of disturbing homeostasis. And many factors play a role in how someone will respond to stress, including age, general health of the person, the type of stressor, how long is this stressor going, and then how do you perceive this stressor, if you have social support, if you have genetic influence to respond to this stressor, and you have neurological responses that helps to cope with this stressor. For instance, the autonomic nervous system will increase the heart rate, the blood pressure, respiratory rate. It will dilate your pupils and increase sweating. And this response, as if you recall, is part of the sympathetic nervous system in what we call the fight or flight. And then within the cerebral cortex also we will be more alert. The limbic system, we will control our emotions, whether we manifest fear, anger. In the thalamus, we also have increased sensory input, like that help us to increase responses of vision, hearing, and then we also have the reticular activating system that maintains us alert when we are dealing with an stressor. Now we also have hormones that are released during stress, like corticotrophin releasing hormone, or CRH. In this case, this CRH is going to stimulate the pituitary gland, so that the pituitary gland releases adrenocorticotrophic hormone, and then you stimulate the secretion of cortisol by your adrenal gland, and cortisol mobilizes nutrients. So you start increasing blood glucose levels from your reserves. Also, you will start breaking down fats and proteins in some cases, and you also release catecholamines like epinephrine and norepinephrine, which are secreted by the adrenal medulla. And this, of course, will have this effect because these are part of the sympathetic system, in which you have, again, increased heart rate, increased blood pressure, and then it will prepare you for fight or flight. Now, when you have this stressor, you will have a response that it is called the general adaptation syndrome. And then this is a neuroendocrine response in which you will have three stages. You will have an alarm stage in which you will have greater alertness because you are under the influence of cortisol, under the influence of epinephrine or epinephrine. And this response, this alarm stage, it's supposed to last for a short period of time, as long as you have a normal response to this type of situation, this type of stressor. Meaning that maybe the stressor will not go away, but emotionally you are able to control the response to this stressor. And then you can have also a resistance stage in which you still have this stressor possibly, but you will suppress these hormones that were released during the alarm stage. And then you have the decrease of the effects of these hormones that were released during this alarm stage. And if you have persistent stress, you will undergo into the exhaustion stage, in which you will have high levels of cortisol, and that will, since it's mobilizing all your nutrients, you will exhaust these nutrients. So you will have hypoglycemia, you can start breaking down your proteins in your body, and that it has a detrimental effect, including that whenever someone has high levels of cortisol, the immune system is not very effective. So exhaustion stage is reached basically when someone has a chronic overwhelming stage. Okay, now let's move into what can be some of the problems of hormonal function. So you might have an impaired endocrine gland, whether because this gland didn't develop, or because you had trauma within this gland, or you don't have enough blood supply into this gland. As well, you can have altered hormonal function because you can have a decrease or increased hormonal synthesis. Impaired receptor binding. Your receptors might be absent, or they might be mutated, and then it cannot bind the hormones. In this case, it can be compared, so for whenever you have your key to unlock your door at home, and then your key falling to the ground, and one of the little peaks of the key get damaged, and as you try to enter and the key into the lock, and then you try to move it to the sides to see if it opens the lock, it won't open because this little part was damaged. Also, in impaired receptor binding, you might have antibodies that might be blocking these receptors. And you can also have impaired feedback mechanisms, in which you will have this failure for this original tissue that sends this releasing hormone, for instance, the hypothalamus, to respond to the negative feedback. Why the hypothalamus might not respond to these negative feedback? Well, there might be a tumor near the hypothalamus or within the hypothalamus that prevents this hormone to reach into these receptors in the hypothalamus, so you can prevent this releasing of this releasing hormone. Or what if the person had a stroke within the hypothalamus and many of the cells within the hypothalamus die, and then these hormones are produced by this gland, they reach the hypothalamus, but you don't have the feedback mechanism. Now, also you can have an impaired cell response to the hormones, majorly because you have these cells that are having this hypoxia as well, or you might not have enough nutrients, and then the cells might try to respond, but they cannot make a hormone because you don't have nutrients available. General manifestations of the altered hormonal function. So, in the case of the pituitary gland, if you produce less of one hormone, it is called hypopituitarism. If you produce more than one more amount of one hormone, that is called hyperpituitarism. In hypopituitarism, signs and symptoms happens gradually. It can include fatigue, weakness, anorexia, sexual dysfunction, growth impairment, and dry skin. Why these many clinical manifestations? Well, it will depend on what type of hormone it is not produced. For instance, if FSH it is not produced, or LH is not produced, the person might have sexual dysfunction because these hormones are related to the function of the gonads. If someone has lack of production of growth hormone, the person is going to have growth impairment. And in hyperpituitarism, you can have the opposite effect. Like, for instance, if someone has excess of production of growth hormone, if the person is during puberty when the epiphyseal plates are still not closed, the person is going to have giantism. Now, how do we diagnose problems with hormones? Well, it's through history and physical examination, and that it will be targeted according to whatever whatever hormone you suspect that it is affected. And then you ask for hormonal levels in serum and in urine. And you can also perform some tests that are called suppression and stimulation tests, in which you inject a substance in the body, and then you expect to have an increase or decrease of the hormonal levels. Also, since many hormones affect the levels of electrolytes, glucose or calcium, you will ask for measurement of this. And also you can do some genetic testing. So treatment will be depending on the cause. So for excess of hormones, if the gland itself it is overproducing these these hormones, you might want to remove part of the gland the part of the gland that it is producing this excess of hormones, or the entire gland. If you cannot do that, you cannot perform surgery, you can give medications that interfere with the effects of the hormone. Now, in many cases, the gland itself might not be affected, but you might have a tumor, a cancer tumor, that it is secreting a hormone. And in that case, hopefully, you can remove that tumor. And with the removal of the tumor, you will get rid of the excess of hormone. And whenever you have excess of hormone produced but not the original gland, it is called ectopic. Now, you can have hormonal deficits, and in this case, you will give exogenously this hormone, the one that it is lacking. Okay, now let's talk about specific problems. SIADH is a syndrome of inappropriate antidiuretic hormone release, which is excess of antidiuretic hormone. Diabetes insipidus is the opposite, so it's when you lack ADH. Hyperthyroidism, when you have excess of thyroid hormones. Hypothyroidism, the opposite. And then Cushing syndrome, in which you have excess of cortisol, and Addison disease, in which you have a lack of cortisol, among other hormones. So we're going to talk about problems of excess of hormones and lack of hormones. So for SIADH, SIADH is the excessive production and release of antidiuretic hormone. Most commonly, this is caused by ectopic secretion of ADH. And a common tumor that secretes ADH is a small cell carcinoma within the lungs. Now, when you have excess of ADH in your body, since ADH helps us to retain sodium and water, the person will have water retention. And then the person will have edema. So this is going to affect the functioning of the cells, but also you will have dilution of the sodium levels. So the person will have hyponatremia. And then you would call that hypotonic hyponatremia. Another clinical manifestation is that you will pee less. Antidiuretic hormone, the name, it tells you that it's antidiuretic. So anti, it's against diuretic, so prevents from diuresis or urination. So the person will have less volume of urine, it will go less to pee, and the urine is going to be concentrated. Now, the clinical manifestations also will depend on how badly affected are the sodium levels. Initially, in mild SIADH, the person will have anorexia, nausea, vomiting, and headache. But as this hyponatremia is worsening, the person will undergo several changes that is going to affect the nervous system. So the person will be irritable, is going to become disoriented, is going to have cramps, weakness, psychosis, gait disturbances, seizures, and coma. So the person can die out of this. Now, hyponatremia initially is going to be less than 135 milliequivalents per liter, and that it can go up to 115 to reach the severe hyponatremia, and then psychosis and problems up to coma. Now, the person will have also hypotonicity because it will increase blood volume levels, and that is going to decrease the levels not only of sodium but also of glucose, chloride, bicarbonate. And then the blood osmolarity is going to decrease, so the person is going to have a plasma osmolarity of less than 280 milliosmoles per kilogram. So that is going to also lead to decreased urine volume. And then again, as I told you before, the urine is going to be highly concentrated with a high sodium content. And then that will happen without the person having renal failure or having problems within the adrenal gland or thyroid gland. So the treatment will be removal of the tumor that it is producing this excess of ADH. And the person has to drink less water. And in order to compensate for the hypotonicity or the hyponatremia, you have to give isotonic solutions or hypertonic, in which you are giving sodium. And then you can also give drugs to treat this problem. Okay, now for diabetes insipidus. So for diabetes insipidus, you have the opposite of SIADH. You're lacking ADH. And in this case, it can be, again, because you have a problem in the hypothalamus. It can be that you have a tumor in there, that it is damaging the cells of the hypothalamus, whether it's exactly within the hypothalamus or nearby, or the person have a stroke. But whatever is the cause, you're not having ADH. And then, since you don't have antidiuretic hormone, in this case, the person will go and pee more. So the person will have inability to concentrate or retain water. And this can be also given because the person might not respond in their kidneys to ADH, or because the person is drinking so much water. Now, why this disease is called diabetes insipidus? Well, Greek doctors on the ancient times, like in the times of Socrates, Hippocrates, they used to diagnose health problems by drinking urine. And whenever they drink the urine of someone who had diabetes mellitus, their urine was sweet, because actually someone with diabetes mellitus is urinating excess of glucose. Okay, and in the case of diabetes insipidus, the person is urinating a lot, just like someone who has diabetes mellitus, but in this case the urine doesn't have glucose, because the problem is not with the pancreas in the production of insulin. So insipidus means tasteless. So whenever they taste the urine of the person who had diabetes insipidus, they just name it like that. Okay. Now, the clinical manifestations is polyuria, so the person will have excess of fluid in their body, and then they will pee a lot, and the person will be so thirsty, just like also people with diabetes mellitus. The person will be dehydrated. It can fall into shock and death. Diagnosis is through history and physical examination. The person can have this increased serum solute concentration, and the ADH levels are going to be low or absent. In the case of the urine, the specific gravity is going to be less than usual, so they're going to have diluted urine, and then the osmolarity of the urine is going to be also decreased. So treatment is going to be treating the cause. In the case of if the person has tumor within the hypothalamus, hopefully that can be removed, and the person needs to be hydrated. And also you can give synthetic ADH or vasopressin, which will be basically the analog for ADH. Okay, for hyperthyroidism, in this case you have excessive thyroid hormone. Now, this excessive thyroid hormone can be because you have overstimulation of a thyroid gland, because someone has antibodies against the receptors in the thyroid gland, or because someone has a problem in the thyroid gland, and you might have excessive production of TSH or thyroid stimulating hormone by an adenoma. Now, Graves' disease is the most common type of hyperthyroidism, and then in this case you have autoantibodies that binds to the receptor of the TSH in the thyroid cells, which are called the thyrocytes, and this is IgH, and then you start producing excess of T3 and T4. Now, the clinical manifestations will be enlargement of the thyroid gland, which is called goiter. The person will have high metabolism, so the person will eat a lot and he will not gain weight, so the person will have weight loss. The person will be agitated, he will be restless, he will be sweating a lot, he will have heat intolerance, diarrhea, tachycardia, palpitations, tremors, which is basically the fingers shaking a lot. You will have fine hair, oily skin, irregular menstrual cycle, weakness, and exophthalmos. Now, all of these clinical manifestations, it's because thyroid hormones, they have effect on several tissues. So this is a general diagram to show you the clinical manifestations, like muscle wasting, enlargement of the thyroid gland, tachycardia, exophthalmos, tremor, oligomenorrhea in the case of females, and weight loss. Diagnosis is through history and physical examination. Lab tests, you will have increased TSH, increased T3 and T4, and you will have what is called free thyroxine levels. T3 and T4 usually are bind to a carrier within the plasma that is called thyroglobulin. But the thyroglobulin in this case is going to be saturated, so you have a lot of thyroglobulin binding to T3 and T4, and then you have increasing thyroxine levels, which is T3. And then if you give to someone radioactive iodine, which is a type of iodide that or iodine that it is taken up by the thyroid gland, because actually iodine is necessary for the formation of T3 and T4, the person will have these cells very active, taking so much iodine to produce more T3 and T4. So this will be the definite diagnosis for hyperthyroidism. So treatment will be give medications that blocks the formation of T3 and T4, and give oral thyroid hormone replacement. This is going to be because whenever you have ectopic tissue that it is producing T3 and T4, you want to remove this tissue from the gland, and then you might induce hypothyroidism in the person, and then you have to give this thyroid hormone. It's not like you are giving more after the person is producing a lot. It's just that it's after the treatment. And also you might want to destroy part of the gland by giving radioactive iodine. In this case, when you do this, you have to quarantine the person, because this radioactive iodine, if you remember, the thyroid gland is very superficial in the neck. This radioactivity goes into the environment, and it can affect persons that are visiting the person who was treated by this. Hypothyroidism is a condition in which the person has deficient levels of thyroid hormone. Causes can be congenital, because a pregnant female didn't had good iodine intake during pregnancy, or it can be acquired. If it's acquired, it's because the thyroid gland didn't develop really well. You have deficient synthesis of TH, thyroid hormone, destruction of the thyroid gland because of an injury or because of surgery, and you can have impaired secretion of TSH by the pituitary gland, or TRH by the hypothalamus. Now, sometimes you can have antibodies against the thyroid gland, just in the case of hypothyroidism. And at the beginning, the person, when he's binding these antibodies to the TSH receptor in the thyroid gland, starts producing excess of T3 and T4, but with time, these antibodies start destroying the gland, and in this case, what is started as hyperthyroidism and then ends up in hypothyroidism. The person might also have genetic defects, injury to the gland, or iodine deficiency. Clinical manifestations are going to be the opposite of hyperthyroidism. In this case, the person is going to have fatigue, weakness, lethargy, weight gain, intolerance to cold, constipation, dry skin, coarse hair. The person might have also problems in the menstrual cycle, impaired reproduction, impaired memory, enlargement of the thyroid gland goiter, and myxedema, which is depositing of some type of connective tissue in several areas of the body. So here is the diagram for clinical manifestations. The person will have periorbital edema, hoarseness, large tongue, or macroglossia, gastric atrophy, constipation, etc. Diagnosis is through history and physical examination. Look at the levels of TSH, which are going to be usually increased in kind of a compensatory way to try to stimulate the thyroid gland to produce more T3 and T4. Free T4 is going to be decreased. Total T3 and T4 uptake is going to be decreased as well. The person might have antibodies against the thyroid gland, and you might have also antibodies against the carriers for T3 and T4, so you will have antithyroglobulin. Treatment is, since you don't have thyroid hormone, you will give T3 and T4. Okay, so for Cushing syndrome, this syndrome has many clinical manifestations that are related to having excess of glucocorticoids secreted from the adrenal cortex in many cases, but you can have also uh, these clinical manifestations coming from intake of exogenous glucocorticoids. So whenever someone has Cushing syndrome, you will have problems in metabolism because cortisol affects also metabolism. Remember, cortisol, it's a hormone that it can mobilize these nutrients in our body. The person also will have an impaired stress response. You will have impaired inflammatory and immune responses. So the causes of Cushing can range from having someone taking glucocorticoids. The person might have a tumor within the pituitary gland that it is secreting ACTH. The person might have a tumor within the adrenal gland that it is secreting excess of cortisol, or the person might have a tumor outside of the adrenal gland that it is secreting glucocorticoids. So clinical manifestations, the person will have redistribution of fat, so the fat will go into the trunk, so the person will have obesity in the trunk. Also, the person will have what is called moon face, so you will have excess of fat within the jaw. Also, the person will have fat within the upper back, so you will have a hump. The person will have intolerance to glucose, decreased inflammatory response and immunity response, so the person will have more likelihood to have infections. The person will be irritable, and you will have an impaired stress response. And as the person it is using proteins, the person will have muscle weakness, that it is manifested by having thin extremities, as you can see here in this diagram. And the person will have reabsorption of the calcium, so the person will have osteoporosis. Increased facial hair in females, which is called hirsutism. And then the person, since it's going to have excess of fat within the trunk, you will have developing of estriae. So diagnosis is to measure cortisol levels in 24-hour urine, which is going to be increased, and imaging studies to detect if the person has tumors that are secreting these glucocorticoids. So just in case that the person is not taking exogenously glucocorticoids, you have to find where these glucocorticoids are produced in the body. So treatment is to remove the cause of excess of cortisol secretion, and then gradually taper exogenous glucocorticoid medications, and remove these tumors if they exist through chemotherapy, surgery, or radiation. Okay, so for Addison's disease, it happens rarely, but it's a deficiency of ACTH, and it can be that, or it can be that the person has ACTH, but their adrenal gland, the cortex, is destroyed by antibodies. So you will have an autoimmune disease person. Now, the problem is that the adrenal gland, independently of the cause, is not producing glucocorticoids, mineralocorticoids, or androgens. These three hormones are produced by the adrenal gland. And at the beginning, ACTH will be increased to stimulate the secretion of these hormones, but since they are not produced, the person will have these deficiencies of the hormones. Now, the person will have clinical manifestations like darker pigmentation of their skin, because ACTH also stimulates the production of MSH, which is melanin stimulating hormone. Melanin is the pigment of our skin. So if someone has excess of ACTH and consequently excess of melanin stimulating hormone, the person is going to produce more melanin. Now the person is going to have deficiency of glucocorticoids. So cortisol helps to increase glucose levels. So the person, since it's not going to have glucocorticoids like cortisol, the person is going to have low glucose levels or hypoglycemia. The person is going to be weak because it doesn't have enough glucose. And then the person will have poor stress response, fatigue, anorexia, vomiting, weight loss, and personality changes. Also, the person is going to have deficiency of mineralocorticoids like aldosterone. And then in this case, the person won't be able to retain water. So the person is going to be dehydrated, and also the person is going to be unable to retain sodium. So the person is going to have hyponatremia, and aldosterone actually increases potassium in the body. So the person is going to have hyperkalemia, and then since it's going to have low blood volume, the person will have hypotension, weakness, fatigue, and it can go into cardiovascular shock. Diagnosis is based on the clinical presentation, so you have to have a good clinical history and physical examination. If you measure electrolyte level, sodium is going to be low, potassium is going to be high, and serum corticosteroid levels will remain depressed after you have stimulated the secretion of corticosteroids by injecting ACTH. So in this case, stimulation then of ACTH is going to be failed. Treatment: since you have low blood volume, you have to give IV fluids, and you will have to give exogenously cortisol through hydrocortisone, and you can also give oral glucocorticoids and mineralocorticoids like aldosterone. These persons, they can eat so much sodium, so they will have intake of sodium increased. And that's all for chapter 13. Now chapter 14, it's about reproductive system. So the females in their external genitalia have different structures. Like in the vestibule, we have labia minora, labia majora, the entrance of the vagina. Anterior to that, we have the clitoris and this fat pad, the mons pubis. And internally, we have the vagina, that it is covered by this stratified squamous epithelium in reproductive age. And then we have these fornices that are pouches that are anterior and posterior to the cervix. The cervix is the most lower portion of the uterus. Then we have the body of the uterus and the fundus. And the uterus has 3 layers. It has the endometrium, which is the layer that detaches during menses, the functional portion of the endometrium. And then we have the myometrium, which is the bulk of the wall of the uterus. Is made of smooth muscle. And then we have the perimetrium, which is made by the peritoneal membrane. And then coming from the sides of the fundus and well, the region between the fundus and the body, we have the fallopian tubes that has different regions, including the fimbriae, which catches the egg during ovulation. And we have the infundibulum, where you have the fertilization process. And then we have the ovaries that are suspended into the sides of the uterus by the ovarian ligaments. And we have these ovaries that produces the egg during reproductive stage. Our reproductive system in females, it is under the influence of several hormones, including estrogens, progesterone, and androgens. Actually, the precursor of estrogen and progesterones are androgens. Also, it's under the influence of human chorionic gonadotrophin during pregnancy, and also influenced by prolactin and oxytocin. Now, prolactin, of course, acts over the breast tissue, so it can the females start producing milk, and oxytocin helps in the contraction again of the smooth muscle in the uterus during labor and delivery. So this is the phase of the ovaries. So we have two phases. We have follicular phase, in which the primordial follicles, the follicles that we born with, that has these cells that is going to become the egg cell, and that they are going to produce the different hormones, undergo cyclic changes. So the primordial follicles are very small during early stages of the follicular phase, and then under the influence of FSH, follicular stimulating hormone, these primordial follicles will start growing, forming a cavity filled with fluid, and these we call them primordial follicles. That primordial follicles will grow into the secondary follicles, and then you will have these primary oocytes form into secondary oocytes, these ones that you can see in here. And then under the influence of this FSH, these secondary follicles will grow more, and then they will form what we call the preovulatory follicles, in which this oocyte is mature enough to be ovulated, and then ovulation happens at day 14 of the menstrual cycle under the influence of the hormone that we call luteinizing hormone, or LH. Now, during the luteal phase, this part of the ovary that has released the egg cell is going to seal, is going to internalize, and then is going to form what we call the early corpus luteum. This early corpus luteum is going to start secreting progesterone. And then this early corpus luteum is going to grow, and it's going to form what we call mature corpus luteum, which is going to secrete more progesterone. Now, this progesterone is going to be important for the increasing of the thickening of the endometrium during days 15 to 28, just in case that this egg cell that it was ovulated during day 14 undergo fertilization by a sperm cell. So the thick endometrium is going to be important for providing nutrients to the implanted fertilized egg cell. And then if fertilization doesn't happen, this mature corpus luteum is going to degenerate and is going to form what we call corpus albicans, in which you don't produce any progesterone because pregnancy didn't happen. So there is no purpose for maintaining this endometrium enlarged or thickened, and then this endometrium will fall during the first days of the menstrual cycle into what we call menses. Now notice here that all of these events happen into this area, whether if it's the follicular phase or the luteal phase, happen within this area of the follicles, sorry, of the ovary, that we call the cortex. So this is the cortex of the ovaries, and this will be the medulla, into which the ovarian blood vessels and lymphatics come in and out from the ovary. So this is the uterine cycle matched to the ovarian cycle in here. So if you see here in the y-axis, you can see the days of the uterine cycle. So from day 0 to 4, you have the menstrual phase, in which the endometrium falls down. And in this case, you have, for the ovarian cycle, the growth of primary oocytes into secondary oocytes. From day 4 to 14, you have what is called the proliferative phase, in which the endometrium starts thickening gradually, and then your spiral arteries of the endometrium start also enlarging to provide blood supply to the tissue of the endometrium as it's growing. Together with these endometrial glands start enlarging and connecting to the surface of the endometrium. Now, proliferative phase is under the influence of estrogens. So estrogens are a growth factor for the endometrium. Now, at day 14, under the influence of LH, you have ovulation. So your mature oocyte will exit the ovary, the cortex of the ovary, and they will be catched by the fimbriae of the fallopian tubes. And then you will have, from day 14 to 28, what we call the secretory phase. And then in here, you will have more tortuosity of these glands, the endometrial glands, which are going to be secreted glycogen into the surface. And then if the oocyte that it was ovulated on day 14 was fertilized, these glands will provide nutrients together with the blood flow coming from these spiral arteries to the embryo. Now, during this secretory phase, we'll have progesterone levels high because you have this corpus luteum secreting progesterone. Now, during the proliferative phase, we still have progesterone, but they will be at low levels. And during the secretory phase, we will have estrogens, but at low levels. Okay, so for the male reproductive system, the male reproductive system is composed of the testes, which are found within the scrotum, and the testes will be continuous with this structure that is found posteriorly and superiorly, and also a little bit inferiorly, embracing the testicles that we call the epididymis. And then the epididymis connects to this long tube that we call the vas deferens. Now, inside the testes, the males have these seminiferous tubules that produces the sperm cells. The sperm cells are going to be maturing here. So they will travel into the epididymis, and then the sperm cells in the epididymis are going to mature. And then once they are mature, and then they are ejaculated, they can follow the pathway into the prostate gland, and then into the spongy urethra, and well, the different parts of the urethra, by using the vas deferens. Now, in this region, close to the urethra, the males have these seminal vesicles that, together with the prostate gland, they secrete some fluids that are rich in bicarbonate ions to neutralize the pH of the vagina in females, which is acidic, so they can help in the survival of the sperm cells. Along with this, the seminal vesicles secrete a fluid that is rich in fructose that provides these nutrients so that the sperm cells can generate ATP, and then they can migrate easily within the reproductive tract of females. Now, the prostate gland surrounds the prostatic urethra, which is the first part of the urethra, and then you have the membranous urethra here, and then you have the spongy urethra here. The penis, it is the copulatory organ in males. It is made by this cavernous body, which traps blood during erection, and then is made by this spongy body. Now, the testicles are formed in males during intrauterine life. They're formed in the actual abdominal cavity, and then they descend through the inguinal canal and reach the scrotum. This is going to be important because sometimes the testicles, more likely unilateral than bilaterally, they don't descend. And then when this is detected in the newborn, you give some time for this descending of these testicles to happen. But if it doesn't happen, then the males, they have to undergo surgery. And we will see this in a few slides. Now, the males also are the male reproductive tract. It is under the influence of several hormones like GnRH, FSH, which stimulates the production of sperm cells, while LH stimulates the production of testosterone. And of course, testosterone is necessary for the production of sperm cells. And then the males, their reproductive organs is under the influence of testosterone, and also they produce a hormone that is called inhibin that decreases the production of FSH and GnRH, and also that's the same for females. So GnRH and FSH is inhibited by inhibin in this feedback loop that you can see here. It's a negative feedback loop. So problems in reproductive function is when a person has hormonal imbalance, motility impairment in the case of males, their sperm cells, immune problems in which sometimes you can have autoantibodies. General manifestations of reproductive dysfunction will be infertility given by lack of FSH, LH, irregular menstrual periods in females, amenorrhea, or lack of menses, anovulation, because it might be a problem of LH, that LH is not stimulating the ovaries for having ovulation. And in the case of females, for pain will be dysmenorrhea, or in case of both sexes, dyspareunia, or pain during sexual intercourse, or endometriosis as well. Diagnosis is through history and physical examination. Uh, in the case of when someone has infertility, check for cervical mucus changes, basal body temperature during ovulation, which by the way it's supposed to increase 1 degree Celsius during ovulation. Doctors often ask for a couple who wants to have progeny, if they didn't have it for a long time, check the temperature of the female, and then during day 14 you expect to have increased body temperature, and that's when sexual intercourse is advised around those days. By the way, sexual intercourse, it is more likely for doing it while it is previous to ovulation, and 24 hours after ovulation. That's when you have more chances of fertility. But after 24 hours after ovulation, chances of pregnancy are very reduced. In males, the sperm cells can live up to 3 days or 72 hours within the reproductive tract, so of females. So that's why 3 days before ovulation and during ovulation, it's okay to have sexual intercourse, but 24 hours after, the chances of pregnancy are reduced. Also, you can have a diagnostic test of semen in which you analyze count of the sperm cells, also the structure of the sperm cells and motility. Ovulation analysis through ultrasound, and in the case of females, you can have what is called hysterosalpingography for checking that actually there is not a obstruction of the fallopian tubes or a problem in the uterus. Treatment will be depending on the cause. If there is an infection of the reproductive tract, you have to give antibiotics. You can induce ovulation with drugs like clomiphene citrate. And in this case, this drug can induce ovulation of more than one egg cell. So you can have multiple eggs being ovulated. Then if there's an obstruction, you have to remove it with leiomyoma. If definitely no treatment can happen that it can increase the chances of fertility, you can give supportive counseling and education. And then a couple might opt for having artificial insemination and in vitro fertilization, and probably having a surrogate mother. Okay, so now let's talk about specific problems of reproductive dysfunction. So PID, or pelvic inflammatory disease. This is a condition in which you have inflammation of pelvic cavity that usually happens by infections of the reproductive tract, or STDs. Now, in this case, the most common cause will be Chlamydia trachomatis or Neisseria gonorrhea. Both are bacteria. Chlamydia trachomatis, not all the types of chlamydia causes this PID, certain subtypes, and in this case this is an intracellular bacteria, Neisseria gonorrhea, it's Diplococcus gram-negative. And these bacteria ascend through the reproductive tract of both males and females. Now, another cause would be inflammation and an immune response. And in some cases, when the bacteria ascends and reaches the fallopian tubes, it will lead to an inflammatory response within the lumen of the fallopian tubes that is going to destroy the fimbriae within the fallopian tubes, and that is going to lead to scars and leading also to a purulent exudate. And if it leaves scars, you reduce the lumen of the fallopian tubes, and then of course you can have ectopic pregnancies if the lumen is not completely obstructed. Sperm cells are very tiny in comparison to the egg cells, so the sperm cells can go and fertilize an egg passing through a small gap within the fallopian tubes. But the zygote, which is the name of the fertilized egg, so the zygotes will start growing, and then as it's growing, it cannot pass through this tiny lumen of the fallopian tube, and then as it's growing, it's going to lead to rupture and hemorrhage, and of course this is a medical emergency, so in the fallopian tube, so this can happen. Now, PID, it happens gradually, so it will be asymptomatic in early stages, but later on it's going to lead to inflammation within the pelvic cavity, and then the person will have pelvic and lower abdominal pain. The person, you will have purulent cervical discharge that, depending on what type of bacteria it is, it's going to be the color and the smell of the bacterial discharge. And then the person is going to have cervical tenderness. So you will have dyspareunia, you will have fever and malaise. Diagnosis is through history and physical examination. The person will have lower abdominal tenderness, adnexal tenderness, which is basically having inflammatory response within the ovaries, which are called an annex, or also the fallopian tubes, and cervical motion tenderness. When OBGYNs, they inspect the vaginal cavity, they touch as well the cervix with the tip of their fingers, and they move it from side to side or up and down, but more than likely side to side, and then the female will have pain when the doctor is doing this. Lab studies, ESR is going to be increased, CRP is also going to be increased, and if the person has an active infection, the bacteria is going to show in the studies. Now, one thing to keep in mind about this is that whenever someone has an STD and it has sexual intercourse, that it is unprotected, the sexual partner or partners have to be treated too, to prevent reinfections. And at some point, when there is a case of infertility, just for you to remind you that bacteria, when it's ascending into the fallopian tubes, it's not going to say, well, I have a preference for the right fallopian tube or for the left. It will migrate into both more than likely, and then it will cause scars within the fallopian tubes in both sides. And for the males, it's going to be the same. Okay, so the bacteria will ascend into the urethra, it will reach the vas efferens, and as well it can go up to the seminiferous tubules, but as it's ascending, it's going to lead to inflammation of the lumen of the vas efferens, and then it's going to cause scars, and then the sperm won't be able to travel. So it's STDs are cause of infertility in both males and females. So treatment will be give antibiotics either orally or intravenously, and it has to be specific for what type of bacteria is causing the infection. And then if it's a high-risk patient like a pregnant uh, woman, or if it's an immunodeficient person, it has severe illness, you have to hospitalize the patient. Okay, polycystic ovarian syndrome, PCOS. So polycystic ovarian syndrome is a condition in which you have many cysts, many cysts within the surface of the ovaries. And this is due to the absence of ovulation. So you have growth of these primordial follicles, and then you form primary, secondary, and tertiary follicles or mature follicles, but you don't have ovulation. Why? Because you have excess androgen production from the ovaries. So the ovaries, in order to produce these estrogens and then this progesterone, it has to intake cholesterol. And then cholesterol is going to be converted into an androgen that is called androstenedione. And then this one is going to be converted into estrogens. But there is a problem that is unknown, so this is idiopathic, in which these androgens are not converted into estrogens. And then the person, since it's not going to have these estrogens, is not going to undergo these cyclic changes that happens within the ovaries, and then you just start stimulating these follicles to grow, but you won't have this ovulation. And in this case, then the person is going to have both the ovaries left and right overextended or over distended because it will have this cyst. Now, the person will also develop insulin resistance. Clinical manifestation is going to be menstrual irregularities. The period is going to be shorter or larger, but never is going to be at irregular intervals. And then the females, since they're going to have excess of androgens, it will have growth of hair within their facial area. So you will have hirsutism, you will have acne, and also you will have male pattern baldness. You will have also obesity, and it's going to have a dark velvety skin within the back of the neck into what we call acanthosis nigricans. So the Endocrine Society, in order to have diagnosis, recommends having at least two of the following: excess of androgens, ovulatory dysfunction, or polycystic ovaries. And then you have to perform hormonal analysis, in which you have more than likely excess of FSH and excess, of course, of androgens. And then if you perform an ovarian ultrasound, you will see in the surface of the ovaries enlarged oocytes. And this is a biopsy that you see here. And if you see, this is the surface of the ovary, the cortex, and then you see a lot of cysts. Treatment is give medications that oppose androgens, like giving low-dose birth control pills. Also, you can give anti-estrogen medications that induces ovulation in the case of the female who wants to have pregnancy. And in order to decrease insulin resistance. You can give drugs like metformin, and hopefully you will be able to achieve ovulation. Also, if the female uh, doesn't want to have progeny, might have already have enough progeny if she has it, she might have to have surgery and removal of the ovaries and then treat the symptoms. Okay, so now ovarian cancer. So ovarian cancer has genetic factors associated with it, like having two or three direct family members, like possibly mom, uh, the sister with ovarian cancer, and genes within this family that like BRCA1 and BRCA2, which are called breast cancer 1 and breast cancer 2, are also found in ovarian cancer. Uh, Many times the person has a history of breast cancer, and if the mutation is happening within one of these two genes, the chances of having breast cancer associated together with ovarian cancer are less likely. But when the person has mutation in BRCA1 and BRCA2, the person has breast cancer, more than likely the person is going to have ovarian cancer. The person also has environmental factors associated with it, like ovarian trauma. The more that the female has ovulated, the greater the chances are to have ovarian cancer. For instance, having early menarche or first menstrual period and late menopause increases the chances of having ovarian cancer. The use of hormonal therapy after menopause. Estrogens are a growth factor. So if the female has used or hormonal replacement, uh, that increases the chances of having ovarian cancer. Ovarian cancer has many types, like epithelial, germ cell, or sex score. The most common type is epithelial ovarian cancer, the one that happens within the cortex. And it will have several stages, number 1 through 4 in Roman numerals. Number 1 is more mild than number 4. Is limited to one or both ovaries, while number 4, you have distant metastases. Now, ovarian cancer tends to metastasize locally first into the pelvis, into the urinary bladder, the colon, and then it tends to go through lymphatics into areas outside the peritoneum and the pelvis. Clinical manifestations, unfortunately, are often asymptomatic, and as we age, we have more likelihood to having ovarian cancer. So more than likely, you will have a female who's over 65 years of age coming for big abdominal bloating, and then as the disease is progressing, the person is going to have abdominal distension, so it will have visible increased abdominal distension. The person will have pressure and pain within the pelvic and abdominal cavities. And within the risk factors is not only having increased age, hormonal therapy, early menarche, late menopause, but also the female may have a history, as we said, of breast cancer, but very likely the female also smoked for a long period of time or is actually smoking. And this is how ovarian cancer looks like. Definitely you see that this is not normal. It's not as we see in polycystic ovarian syndrome, in which you don't have even this bleeding. So diagnosis is through history and physical examination, palpating bimanually the ovaries. In many cases, this is detected through surgery, that it is exploring something outside of the pelvic cavity, and also through laparotomy to obtain tissues for analysis. Definitely diagnosis is through cytological examination of the ovarian epithelial cells and by having increased tumor markers. Treatment is based on the stage. Surgery more than likely in stages 1, stage 2 possibly, stage 3 and 4 you might be giving chemotherapy and radiation because you have metastases by that time. Okay, for menopause. So menopause is having a cessation of functioning of the ovaries that happens over the age of 48. Sometimes it's over the age of 55. And in this case is the absence of menses by 1 year. Now, this can happen because you don't have activity of the ovary cells as you stimulate these ovarian cells with FSH and LH. Why? Because as we age, these cells, as many cells in the body, they become atrophic. So you have excess of FSH and LH, but your ovaries are, the cells of the ovaries are very thin that they don't respond to FSH and LH. And then, since these ovarian cells supposed to produce estrogens under the influence of FSH, you don't produce these estrogens. And then estrogens are a growth factor for so many cells. So that will have the rise of many of the clinical signs and symptoms. So clinical manifestations, they occur as a result of loss of estrogen. So our ovaries don't respond to FSH, so we don't produce this estrogen. And estrogens are necessary for the growth of the endometrium. So if the endometrium doesn't grow, the endometrium will not fall, so we don't have the menses. And the menses has to be absent clinically for 1 entire year without, of course, the female being pregnant. And then that year has to be continuous. Those 12 months, sorry, has to be continuous without menses. Now, estrogens are a growth factor also for the breast tissue. So the person who will have decreasing breast size, decreasing the skin elasticity, thinning of the skin, thinning of the body hair, thinning of the subcutaneous fat, and atrophy of the ovaries and the uterus, thinning of the vaginal walls. The person will have dyspareunia, so less elasticity of the vagina, increased urgency for urinating, and stress incontinence. Along with that, hot flashes, changes in the mood, depression, irritability, mood lability, anxiety, fatigue, sleep disorders, decreased libido, bone loss, and cardiovascular disease. So estrogens are a protective factor for having coronary artery disease. So chances of having occlusion of the coronary arteries happens after menopause at the same rate as males. Diagnosis again is having at least 12 continuous months without amenorrhea in absence of pregnancy, and increased FSH, decreased estrogens, and decrease in inhibin. Treatment is giving hormonal replacement that is not solely estrogen. It also has to be given in combination with progesterone because it reduces progesterone the effects of estrogen in a way, so it maintains an equilibrium. If you only give estrogens as replacement therapy, you are increasing having the chances of ovarian cancer and also having the chances of breast cancer because again estrogens are a growth factor, so it can increase the activity of mitosis of these cells. So also you can give what is called selective estrogen receptor modulators, raloxifene to prevent osteoporosis, and non-pharmacological treatments, that is avoiding spicy foods, caffeine, alcohol, because that increases changes in mood, and relaxation techniques and exercise. Exercise is very important because reduces the chances of osteoporosis. And so many females opt to not have this hormonal replacement therapy because at some point that can induce the menses, and many females are tired of them. Okay, so now let's move into erectile dysfunction. So erectile dysfunction is the inability to achieve or maintain an erection that is sufficient for satisfactory sexual performance. Factors can be hormonal issues that actually happens in males after the age of 40 because actually testosterone are decreasing, just as in females. Estrogen levels decreases after the age of 40 or so. In males as well, testosterone level decreases, and testosterone is responsible for increased libido. Also, the male will have neurological problems, including things like diabetes mellitus, in which you will have obstruction of blood vessels that provides blood supply to the nerves. The male might have problems with the sacral nerves, S2 through S4, which are the ones that helps in the formation of this stimulus for erection. Also, vascular obstruction of the pelvic blood vessels, psychological issues like anxiety, low self-esteem, depression. They might have problems with the veins or the blood vessels within the penis, and certain medications, certain antihypertensives can cause erectile dysfunction. So clinical manifestation: inability to achieve and maintain erection. Diagnosis is through history and physical examination, measured hormonal levels. Testosterone is one, LH as well, because if LH is low, testosterone levels are low. What if LH and testosterone levels are normal? Well, the problem might be in testosterone receptors. Okay, it's difficult to diagnose this because there is no specific test, but in this case, when LH and testosterone levels are normal, they might be lack of sensitivity to testosterone by the receptors that might be mutated. Thyroid hormone, also you have to measure, and prolactin levels too. Treatment is psychosocial support. Give drugs like Viagra, vardenafil, tadalafil, which increases vasodilation so that more blood goes into the penis. Now, at some point, they can have a secondary effect like hypotension, so you have to let the male know about this secondary effect, and then penile implants also can be also used as treatment. Okay, so for benign prostatic hypertrophy, or BPH, actually it's hyperplasia, not hypertrophy. Okay, so benign prostatic hyperplasia The cause is unknown. As the males age, they have also the chances of having growth of their prostatic gland after the age of 40. Hormonal changes associated is reduced testosterone, increased proportion of estrogens, and dihydrotestosterone. And this will lead to increase of growth of the cells within the prostate gland, so hyperplasia in the area around the urethra. So it's within the central lobes of the prostate gland. And one good thing about this growth of the prostate gland is that it's not associated with cancer. Clinical manifestations will be increased urinary frequency, dribbling, hesitancy, incontinence, urgency, and retention. Diagnosis is through history and physical examination. For digital rectal examination, you have to rule out that it is not prostatic cancer or suspicious of prostatic cancer, in which prostatic cancer tends to grow in the posterior area of the prostate gland, the one that is close by the rectum. So when doctors they introduce the finger, the index finger in the rectum, they touch the posterior region of the prostate gland, and if it's not indurated or tough, and if they don't feel a tumor in there or a growth, that means that the problem is more in the central area. Now also urodynamic testing, in which if you see increased pressure within the urinary bladder, that means that it's an obstruction distally. More than likely it's only BPH. And of course PSA or prostatic specific antigen is increased, and biopsy is then definitely diagnosis. So you have to take a sample of the tissue in order to diagnose that it is only hyperplasia, but it is not cancer. Treatment is pharmacological. You can give drugs that oppose the action of testosterone, and you can also perform laser heat-based treatments to destroy the prostate gland, but more than likely it's going to be surgery in what we call transurethral resection of the prostate gland, or place a urethral stent. For prostate cancer, the cause is unknown. Risk factors are age, greater than 60 years, family history of having prostatic cancer, black race, smoking, and nutrition high in fat, because that increases the production of estrogens. Genetic factors, environmental factors are also associated, hormonal factors, and 95% of the cancers that happens within the prostate gland are adenocarcinomas. The treatment, the clinical manifestations are mild, similar to benign prostatic hyperplasia, but usually it's asymptomatic until the cancer is advanced. As well, the symptoms are urinary frequency, hesitancy, incontinence, urgency, and retention. Diagnosis is through digital rectal examination, transrectal ultrasound to see the tumor, the increased prostatic specific antigen, but it's going to be more higher than what you expect for BPH, usually like even 10 times higher. And of course, the diagnosis definitely has to be through biopsy and cytological analysis. And pelvic lymph nodes might be affected too, so you have to dissect one of these pelvic lymph nodes. This cancer also tends to spread locally. It goes into the sacrum or into the lumbar vertebrae, so you have to do radionuclide bone scan to see if this vertebrae has also been affected, and you can classify the tumor according to the TNM classification, that it is specific for this prostate cancer. Treatment, if it's in early stages, will be surgery. If it's in late stages, will be radiation and chemotherapy. And give these drugs that decreases these androgens, and then watchful waiting for the results. Okay, so lastly we have testicular cancer. Usually the cause is unknown. However, it seems like there are some problems in chromosome 14 and cryptorchidism, cryptorchidism is the major risk factor. Remember that I told you that the testicles are formed in the abdominal cavity, and if these testicles, one or both, don't descend, these cells, the germ cells that produces the sperm cells, are subject to high temperature in the abdominal cavity, and this increases the rate of mitosis, which increases the chances of high mutations within the cells. So this testicular cancer can be subclassified in two major types: the ones that are formed in the cells that is formed, the sperm cells, that are called seminomas, and the ones that are not derived from the cells that form the sperm cells, that we call non-seminomas. Now, the most common type will be these seminomas. These are tumors that are small, painless, and that they form a small testicular enlargement in the testicle. Now, these, as they are growing, they can form a heavy mass and an enlargement within the scrotum, that it will cause initially a mild discomfort in the testicle, and that will lead for the male to seek medical attention. And then that's why it's recommended for the males to have self-testicular examination at least once per month. And then if they find this type of this enlargement, they will go to the doctor, and then the doctor can ask for some tests, including tumor markers that will be increased. Now, diagnosis is through as well done by MRI, CT scan, and ultrasound, and the treatment definitely is given by radical orchiectomy. So you don't even wait for just removing a certain part, because actually there are greater chances when you are doing this, even like if you do a biopsy, you can see these cancer cells in the scrotum. So treatment is surgery, radical orchiectomy, so you remove the entire testicle, and radiation therapy if you have metastases. So this is all for chapter 13 and 14. Hopefully you can see all these two chapters completely. It is necessary that you pay close attention and in some cases take notes, or it is highly recommended. But anyway, this is all for this chapter. Have a good day or have a good night. Bye-bye.